is Guardian Radio, your station for up-to-the-minute news and intelligent, interactive, and engaging conversations. 96.9 FM. The views and opinions of the hosts and guests are their own and do not necessarily reflect the views of the management and staff of Guardian Radio.
With early detection comes early prevention.
But letting your pencil make you feel like a champion.
Rise up again, let nothing keep you down. To live your best, hear the urologist speak. Oh yeah.
Think you're losing grip of your manhood. Don't give up on hope.
Don't be ashamed, it's time to take control. Get some help from the urologist.
You will find
He'll help you solve your problems
on 96.9. Yeah.
I telling you, with early detection
Comes early prevention.
but letting your pencil make you feel like a champion.
Rise up again.
Let nothing keep you down. Live your best.
Good evening, Bahamas. This is Bahamian Urologist, Dr. Greggory Pinto. I'm joined, as always, with my co-host, Bahamian Surgical Oncologist and General Surgeon, Dr. Wesley Francis. Welcome, Dr. Francis, again.
Well, thank you, and good evening, Bahamas. It's great to be here and have this conversation on a Wednesday night with our listenership.
So yesterday was World Cancer Awareness Day, so we're going to use that opportunity, and we've been doing that for the last few days, few weeks, in terms of we're talking about cancer, we're talking about screening, prevention, strategies in terms of management. More specifically, we're talking about modifiable risk factors, things that we can actually change to reduce the risk of developing cancer. And I'll let you highlight, Dr. Francis, that U.S. Surgeon General actually highlighted that alcohol has a very strong influence in terms of cancer risk.
Yeah, I mean, we had talked about that before. I think everybody knew before that a lot of cancers was associated with alcohol, but this was the first time that it was actually published by the Surgeon General, and it gave a lot more awareness. It brought more awareness to that fact that alcohol can be carcinogenic in and of itself, and it really gave a direct correlation to the amount of alcohol that you take, even small amounts. We always tell patients, everything in moderation is good, but even small amounts of alcohol, we know, can lead to increased risk of developing cancers, GI cancers, breast cancers, pancreatic cancers, colon even. And this was, we used to notice before, but now it's really been emphasized.
Yeah, so even excess alcohol consumption can increase the aggressiveness of prostate cancer as well. So we're also going to talk about a lot of strategies that we use in terms of screening for the numerous cancers. We're here to be more preventative, more proactive. We're trying to prevent things, not just be reactionary. So we're trying to promote basically longevity. We want you to have a long life. We want you to have a happy life, and that's in terms of physical, the emotional, and the spiritual. So one of the pillars of longevity is minimizing mortality from cancer. Yeah. And how do we do that? We want to prevent cancer.
Yeah, so, yesterday, like you said, was World Cancer Awareness Day, and the Caribbean Association of Hematology and Oncology actually had a webinar where throughout the region, different experts talked about the challenges that we have with cancers. And one of the major thing that came out of that was the lack of prevention strategies, screening programs, and even us in the Bahamas. I mean, we talk about breast cancer all the time. We talk about breast cancer screening, but we don't really have a formal screening program that's nationwide, that's applied nationwide. What we do is what we call opportunistic screening, which, your doctor tells you, go and get a mammogram. Or in October, everybody or a majority of people get screened in October because it's Breast Cancer Awareness Week or month. But what we don't have is a formal program, let's say coming from the Ministry of Health to say, listen, this is our program. This is when you should be screened. This is the test that you should be screened. This is the interval for screening and all of that. And so that came out yesterday. The other thing about cancers that came out in the webinar was the lack of hospice care and palliative care. So yeah, I mean, we try to prevent cancers, we treat cancers, but there's always a number of people who are going to progress and whose treatments are going to fail. And these patients need to be taken care of. And they need to be taken care of in a humane way. And one of the major things is they have a lot of pain. And they need to be treated appropriately and given the adequate amount of pain medication that they would need. And so that's the whole discipline of palliative care that we're actually lacking in the Bahamas.
Well, obviously, palliative care is very important, but we want to stress prevention. Let's prevent people from going down the route of having metastatic disease, advanced disease, where they only are for palliation. And I see that far too often,
yes,
particularly for prostate cancer, which is one of the easiest cancers to treat, where it has a 100% 5-year cancer-specific survival if we pick up the cancer when it's early, when it's organ confined. It has a 97, 98% cancer-specific survival at 10 years. There's so many ways that we can pick up prostate cancer early, even when we can pick it up so early where it's clinically insignificant, where we can actively surveil the patient until it becomes an issue where we need to cure you. So there's no reason that anyone should be dying of prostate cancer. We also talk about colon cancer. We talk about colonoscopies and the need for colonoscopies starting at the age of 45, and how colonoscopies are not just diagnostic, but they can actually be therapeutic. Can you speak a little bit about that, Dr. Francis, in terms of...
So here's the thing, right? And we're pushing prevention, and that's important. But there are several different preventive strategies out there. We talk about primary prevention, secondary prevention, tertiary prevention. And primary prevention is to actually prevent a disease from occurring. That means to stop it from actually starting, right? An example of that is actually a colonoscopy. So a colonoscopy is a primary preventive strategy, because if you do a colonoscopy and a polyp is there and the polyp is removed, you never get colon cancer. So that's primary prevention. Secondary prevention is, for example, when you would have identified a disease. You already have the disease, but you identify it earlier. And a classic example of this is a mammogram. Mammograms don't prevent breast cancer, or they don't stop it from occurring. What the hope of mammogram is to catch it early. So this is a early preventive strategy. And then the last preventive strategy we call tertiary prevention is when you already have a disease, for example. And we try to minimize further complication or improved quality of life. And that's how you manage the disease. So it's primary prevention, for example, a colonoscopy. Secondary prevention would be something like mammography. And then tertiary prevention, if you already have a disease and we're trying to prevent any further complications. So, for example, patients with breast cancer, hormone-positive breast cancer, they'll be put on tamoxifen if they're premenopausal, or Arimidex, which is a hormonal form of treatment, but it's actually a preventive strategy from allowing recurrence or making it worse.
So when we talk about cancer and we talk about management, we always want to talk about local control, and we want to know about systemic control. What is the role of chemotherapy, which is obviously addressing systemic control? When you have any cancer beyond, let's say, stage 1, we'll look at breast cancer, does it mean that you have micrometastasis? Does that mean that the actual cancer cells have gone into the bloodstream?
So here's the thing, right? And it depends on the type of cancer. Let's use breast cancer, for example. We believe that once you get breast cancer, it's systemic from the outset. And this is the whole idea of circulating tumor DNA. And we're going to talk more about that because there's a new test that's out. But cells tend to break off, or cancer cells break off, and they're within your bloodstream. And what happens is, over time, without treatment, those then find fertile ground and grow. For example, they would grow in your liver, would grow in your lung, grow in your brain or whatever like that. And that's metastases that we can identify. Before we identify them, they're microscopic, and this is what we talk about, micrometastases. And this is the whole idea of chemotherapy. And this is why chemotherapy is so important in the treatment of cancers, because chemotherapy kills the micrometastatic disease. And a lot of people say, chemotherapy, and I don't want to do that. But chemotherapy is what saves lives, because people die from cancer because of metastasis. And to prevent that metastasis or to treat that metastasis, the first treat the micrometastasis within the bloodstream, and that's what chemotherapy does.
You mentioned tamoxifen. So when we talk about tamoxifen in terms of what is its role and why do we use tamoxifen to prevent recurrence once you've been cured of breast cancer?
So one of the pathology or pathogenesis, one of the development of why we get breast cancer or why women get breast cancer is because of the effect of estrogen on their breasts. Tamoxifen actually blocks estrogen, but only in the premenopausal women before they lose their period, under the age of 50. And so you want to stop that hormonal environment to cause either the cancer to spread or to come back. And so this is why they use that hormonal therapy to block the effect of estrogen on the breast itself or on the tissues to prevent recurrences. And that's the way it's used.
Well, we've discussed this in the past. Breast cancer is a very diverse disease. So
It's
not every type of breast cancer,
no.
tamoxifen will have a benefit.
There
Which types will not have a benefit?
So there are 5 definite subtypes of breast cancer, and this we have to educate people that not all breast cancers are the same. One size don't fit all. Hormonal breast cancer is where tamoxifen, what we call ER positive or hormone responsive breast cancer, that's where tamoxifen in the premenopausal phase, or Arimidex, which is an estrogen blocker in a postmenopausal woman. So only in hormonal breast cancer they work. We have what is called triple negative breast cancer, which is it's a more aggressive form of breast cancer. And there are other types like where we have what is called HER2 positive, which is a target within a cell, Herceptin. That's also a form of aggressive breast cancer. But all of these subtypes, we have to identify them before we actually treat. And so this is why it's important for all the initial workup to identify the exact type so that we can know which treatment to actually apply.
Okay, so we have a call.
We have a caller? Great.
Good evening. This is Urologist Speaks.
Hello, good evening.
How are you doing?
Yes, I'm listening to Doc here as it relates to cancer. It seems to be incurable, with the age of the internet and the information overload. There are alternative forms of therapy, right?
Yes.
So I read one some years ago, and as it relates to cancer metastasizing, right?
Yes.
So I just wanted to know, is the lymphatic system the way in which the cancer metastasizes? Now, we know that oncogenesis could be triggered anyway, I guess, from, environmental factors, external factors. So, I mean, for me, the question is, I guess cancer is a retrovirus, but most doctors and most people won't admit to the biological weapons program. And I've had a doctor friend actually admit it to me of the recombinant technology and the results of what they discovered and what they did with simian virus, et cetera, et cetera. But I want to get on with the cure for cancer. I've read where if you block up the lymphatic system, I don't know what's the practicality of it or the side effects, but I just wanted to know, is the basics, the fundamental spread is through the lymphatic system, because I've read where they can, I guess they take out lymphocytes or just impede the flow to stop it, and what would be the side effect of that versus all of the chemo and all of the other therapies, well, maybe nutrition therapy and some other innovative that I've seen from Dr. Kaczynski and those, like, you know what I mean, as far as T-cell immunity. And does the cancer cause T-cell exhaustion or immune exhaustion? I'll just hang up and listen.
So thanks for that question. And So cancer spreads in various ways. There's what we call hematogenous spread. That's where it would spread through the bloodstream. And there are certain types of cancer that spread through the lymphatics. And so, as you mentioned, that would be through the lymph nodes, right? Because the lymphatics is basically a filtration system. So if you have an organ that has a foreign entity, which could be a cancer cell, then it's filtered through these lymphatic channels and they go to the lymph nodes. And so hence, for example, a case of breast cancer where women tend to present sometimes with swelling under their arm. And so that's really an indication that the tumor has already spread from the breast and went to the lymph node. That's just one mode of spread. Others, like for example, colon cancer can sometimes spread directly to the liver. And that's a mode of hematogenous spread where it goes through the bloodstream and it rests in the liver because the liver is a very fertile ground for it. So there are different ways. Colon cancer can also spread what we call transcoelomic spread, which it spread to the lining of the abdominal cavity and didn't even go to the lymph nodes nor go to. So it's multifactorial. Cancer is not a simple disease, and it's not a simple cure. And I would say that the way to treat cancer is a multidisciplinary approach. There's no magic bullet out there. Okay, and when people start to talk about a magic bullet, this can cure it, this can cure it, there's no scientific basis in that. It's a multidisciplinary approach where accurate diagnosis, accurate characterization now, and then appropriate treatment. And the treatment involves surgery, radiotherapy, and also systemic therapy or chemotherapy. And that's what we do. That's the approach that we have to treating cancer.
Okay, I think it's important that we define what exactly is cancer. So cancer is both a genetic and metabolic disease. What drives cancer? Cancer is unregulated cell growth, cells that grow without responding to normal cell growth signaling. There's a strong immune response to cancer. So I think that's an opportune time for me to ask you this question. So it's been revolutionary in the last at least decade, or even more than that. Immunotherapy. What is the role of immunotherapy? What is immunotherapy? I've seen miracles happen with immunotherapy with prostate cancer, with bladder cancer, where lung metastasis, liver metastasis have disappeared.
So one of the, I think the most basic way to talk about this is that your immune system is an army of cells that's there to basically fight anything that's foreign to your body or anything that's trying to harm your body. And so cancer cells can be viewed that way. And one of the ways that that immunotherapy functions is that it arms the immune system or improves our local immune system to actually fight cancers. Now that could be either in helping the immune system to identify them, right? That's one way. And that may be by targeting the cancer, giving it receptors such that the immune system would recognize it. So your own immune system actually kills the cells. Or it could be empowering your cells then to then further or activate your cells such that it would attack this foreign material. That's the whole basis of immune system. It has been worked well with melanoma. And now with triple negative breast cancer, it's actually working very well. And this is one of the reasons why we try to get the subtype, because triple negative breast cancer before used to be, it's very aggressive and high mortality rate. But now with immune therapy, what we're seeing is actually very great results because people get immunotherapy and you start to see the tumors actually melt away. So this is something that, again, is another arm of therapy that we have, and it has brought a lot of hope to people.
So let's talk. So cancer is strongly influenced by the immune system, as you said. It's also influenced by the metabolic health of the individual and also the ability of the individual to acquire mutations and to repair them. So when we talk about genetics and cancer and genetics. We talk about genetic screening. We talk about the genetics in terms of management itself. So in terms of genetic screening, essentially we're looking for germline mutations. So these are genes that are inherited from our parents. So these involve looking at the genetic sequencing themselves. The problem with that is that the vast majority of cancers do not arise from inherited germline mutations, but from somatic genetic mutations. So only 5% of cancers come from inherited genetic mutations. 95% come from acquired mutations, which are called somatic mutations. And this drives most of cancers. So when we're doing genetic testing, we're missing a lot of persons who are at high risk because of acquired, or even a lot of cancers that are brought on because of modifiable risk factors, such as cigarette or cigar smoking, or obesity, or sedentary lifestyle, or, as we mentioned, alcohol consumption, even in low levels. So we look at the top 2 modifiable risk factors. Obviously, everybody knows it's cigar and cigarette smoking.
And tobacco,
and I have to emphasize cigar because baby men don't want to hear that. Many studies have shown cigar smoking is even more hazardous than filtered cigarettes. But a lot of men think, oh, they don't really inhale, but they'll just get around with half a dozen of their friends every single evening and smoke and play dominoes and play cards or talk. And even the secondhand smoke from their friends is horrible. Just from the perspective of a urologist, bladder cancer is very, very strongly linked with cigar smoking. And I see more and more throughout the years of men coming in with bladder cancers. It used to be a rarity. Now I'm probably diagnosing 2-3 a month, which is alarming. And that can be basically preventable if you didn't engage in cigar smoking. So a lot of men don't want to hear that. They don't want to hear that you shouldn't be consuming so much in the way of alcohol.
Choices, right? I mean,
they're choices, yes.
Yeah, because I mean, anything you heat up and inhale, I don't think you're supposed to be inhaling heated elements at all, whatever it is, right?
Even vaping is dangerous.
Well, we know that.
A lot of people don't.
True. Well, they know. They just choose to do what they want because they get some sort of benefit they feel from it, and so they choose that. The problem with anything that you do is that the effects of it are usually delayed. It's over time. If I smoke a cigarette or cigar today, I'm not going to feel bad today. I'm just going to feel the benefit of why I'm smoking it. I'm going to get that great feeling but if I keep that as a habit each day, that small incremental effect, and that incremental effect adds up over time. And this is why a lot of people, you can tell them over and over, smoking is bad, alcohol is bad, but they still drink because there's no immediate effect other than the relief that you get, or the sensation that you get by using it today. Whether it's tomorrow or a month from now. And that's hard because sometimes people, it's disconnected from them. And it's only when they maybe see a relative or they start to feel something in themselves, then they realize, oh, wow, perhaps I need to change this.
And then we talk again with modifiable risk factors, obesity or being overweight. That strongly influences all. Yeah, influence. And we have an overwhelming problem in this country. We're with the 4th highest rate of obesity per capita in the world. I mean, that is very, very sombering.
It's a hard thing, and I got to say, especially in our population, it's a hard thing. Dealing with obesity is difficult. Psychologically, I know a lot of men and women who work hard to try to alter their lifestyle, to try to lose weight. It's hard. It's not easy. So my heart goes out to everybody. I myself, I try to do as much exercise as I can, and I got a little bit of weight on me too. But it's not an easy thing. But it's something that, again, a habit that has to develop. I think it has to be a lifestyle thing that you try to do, and this is how you try to stay healthy over time. There's some shortcuts. I'm always getting asked about certain drugs to burn fat and all of that. Those things aren't healthy. And now you know that there are a lot of medications out there, the GLP-1 inhibitors. Fat melts away. But, the studies aren't always out of the long-term side effects of these things. So I think what we do know is diet, exercise, it helps, but it's hard. It's not easy. And I think that we have to continue to encourage people, and as they see benefits, that'll serve as an incentive for them to continue on.
And then a lot of people don't really understand what is the real link between being overweight, being obese, and getting cancer. So I look at it from this perspective. It's not the extra adiposity. It's not that little extra love handle or those 5 pounds around your midsection that increases your risk of cancer. It's a little bit more complex in that. It's related to obesity and what it causes. It causes an environment of growth factors that come with the disease, and obesity is a disease in itself. So namely, we're talking about hyperinsulinemia. We're talking about clinically elevated IGF and other immune factors. We're talking about the inflammatory environment associated with being overweight or obese. So it is due to the excess fat that spills over from the adipose tissue around the visceral organs, and that might include the kidneys, the pancreas, the heart. In particular, for the pancreas, it affects cancers in twofold. First of all, it increases the risk by reducing the amount of insulin that the beta cells can produce, are released by the pancreas itself. And then it also creates an inflammatory environment around the pancreas.
And I think that's what's important too, because I know a lot of people ain't gonna remember all of that, right? But I think what we need to emphasize is that excess, especially visceral, when we say visceral, we mean around your organs, that creates a pro-inflammatory environment. And what I mean by pro-inflammatory is inflammation. Inflammation, it's like acute inflammation. When you get a cut, it's what helps you to stop bleeding. When you get a bee sting, you see the swelling that happens there. That's all inflammation. And what it is that your immune system is trying to wall off that area. Can you then imagine that continues in a chronic way? So what happens is that creates a pro-inflammatory environment, and you have a chronic inflammation, because acute inflammation is there to stop any offending agent from harming you. But then if you keep driving that and it becomes chronic, that's when cells tend to start to change. And then they become what we call neoplastic or carcinogenesis. And that's really what happens, is that chronic inflammation. Chronic inflammation is not good, because our bodies are set up for acute inflammation, stop the injury, stop the whatever offending agent, kill it, and then go back to normal. But then if you keep having to recruit those immune cells to keep fighting, it becomes chronic. Then that's why, that's what happens. And obesity creates that pro-inflammatory environment in association with high insulin levels, and this just kind of maximizes that whole situation.
Okay, we're going to talk more about with this fascinating topic on the other end of the break. This is Urologist Speaks.
You try to rest, but roll with the best. For all your printing needs, there ain't no one better, no. For posters and binders, magazines and flyers, for window decals, greeting cards and newsletters. No job too big and there's no job too small. You name it, we can print it, just give us a call. Let Print Masters bring your masterpiece to life.
Located at the Nassau Guardian Building, telephone 302-2361.
Loss of family members is very isolating, and people who have experienced loss appreciate when others have shared their grief. If you can't be there in person, go to the Nassau Guardian's website online at thenassauguardian.com and visit our obituary link. The Nassau Guardian's interactive obituary link allows you to read the funeral announcement, express condolences, or place photos on the online guest book for 1 full year. Losing a loved one is painful, but that pain isn't the worst thing to happen. Friends, loved ones, colleagues, and neighbors who ignore the loss compound the pain. Should the bereaved family wish to place the obituary and photos on our obituary site, just contact the Guardian's funeral industry partners or the Nassau Guardian. Remember, there isn't one magic right thing to say to someone experiencing loss that will make the loss less painful or easier to bear. The Nassau Guardian's obituary link, available online at thenassauguardian.com.
Always on the go? Missed the show? You can now listen to Guardian Radio talk shows anytime, anywhere on Spotify and YouTube by searching Guardian Radio 96.9 FM or by entering the name of your favorite show. You can also listen by logging on to GuardianTalkRadio.com and clicking on the podcast tab. Guardian Radio, continuing to provide you with fresh news and smart talk anywhere, anytime, all day.
Love the show? Want to give your support? Become a sponsor today. Call 302-2300 for our rates and packages. That's 302-2300. Become a sponsor on Guardian Radio 96.9 FM. Fresh news, smart talk, all day.
This is Guardian Radio 96.9 FM. Fresh news, smart talk, all day.
Welcome back. This is Urologist Speaks with Bahamian urologist Dr. Greggory Pinto and Bahamian surgical oncologist Dr. Wesley Francis. We're talking about cancer. We're talking about modified risk factors. We're talking about screening. We're talking about primary, secondary, and tertiary strategies for prevention itself and all the management options available for the various cancers. But just before the break, we were talking about obesity and the effect of obesity on cancer. So even if 10% of our total body fat were to enter or involve the viscera, which would be the liver, the heart, the kidneys, the pancreas, it can exponentially increase our risk of cancer. If the fat actually enters in or accumulates around the muscle, it can directly affect and contribute to insulin resistance. And basically, cancer is driven by glucose. Insulin resistance related to obesity and other factors can exponentially also increase our cancer risk. But let's talk to you as a breast cancer expert. Obesity in postmenopausal women and breast cancer. What is the link?
So again, remember we talked about the hormonal effects of estrogen on the breast, and that's a risk factor for the development of breast cancer. So in the postmenopausal women, when the premenopausal women, estrogen is produced by the ovary. In the postmenopausal woman, estrogen is actually produced within fat cells. So all the androgens or the hormones that are produced by the adrenal gland goes into the fat cells, and there's an enzyme within the fat cell called aromatase, and this then converts all of those androgens into estrogen. And that estrogen now has an effect, and this is particularly in postmenopausal women, that estrogen has an effect on their breast and increases their risk of development of breast cancer. So in a postmenopausal woman who's obese, you can then derive there or conclude then that their level of estrogen is very high. And this is then what is deleterious or that driver for cancer within the breast. And so any woman who is postmenopausal and has breast cancer, a part of the treatment is to actually treat them with what is called an aromatase inhibitor to actually block that effect. So what they found, and this is the correlation between obesity in postmenopausal women and the higher incidence of breast cancer or the worsening in breast cancer. And so that's why we do it.
So that is just one motivation for us to encourage women, well, men as well, to be active in their retirement years. They really don't have a need to get up and go to work, but they need to be active. They need to keep their mind acute. They need to read. They need to engage with other individuals. They need to have something to do, somewhere to go,
Absolutely.
Keep busy, and then keep your body mass index in the normal range. That's extremely important, just in terms of your cardiovascular risk at that age, in terms of reducing your cancer. The number one risk factor for cancer that's not modifiable is age. And that's where we're here. We're trying to allow us to live longer and live better. So if we reach an advanced age, we're at greater risk of cancer.
Definitely.
Yeah.
I mean, really, breast cancer in most places is a disease of older women. It's just in the Bahamas, we tend to have more younger women present with breast cancer, and this is more due to genetic risk. So that's a non-modifiable risk. So if you are part of a genetic family syndrome or known to have the breast cancer gene, and there's some other genes that cause it too. It's not just the BRCA gene. Then this is why you tend to see more younger women with breast cancer. But really and truly, it's a disease of older women. This is something that we even talked about last night, World Cancer Day webinar, because we're finding more and more younger people with breast cancer and also colon cancer, especially in the Bahamas. It's happening. And I'd say to you, not all of these women or males who show up with colon cancer, people who show up with colon cancer, have a genetic problem because we test them. So it must mean that there's something involved, something modifiable that's actually leading to that higher risk. And so
And
this
what's
is
the
a big
role of
problem.
diet? I mean, we have a horrible diet.
I'm pretty sure that diet is probably the number one cause of that. We don't have all the proof, right? But I mean, it's there. What you put in your body. I think there's a restaurant that says food is your medicine, and food could be your poison also. And what you put in your body, again, and as I'd mentioned, it's the incremental thing, right? It's the habits that you develop. If you eat fries every day, I mean, the day that you eat the fries, the endorphins and the dopamine is going to go. You're going to feel real good. But if you do that for next month, every month, then you're going to start to feel the lag, the ill effects of it. And I think because of that, we tend to discount these things that are actually toxic to our bodies.
We even look at domesticated animals. We look at dogs, for example. And what's the number one cause of early death in dogs? It's cancer. Well, their studies have looked at packs of wild dogs out in the wilderness where they have a certain diet. There is no cancer in these wild dogs. So you can extrapolate that it's because of the domesticated animals receiving the food that we give them that leads to their cancer.
Well, one of the largest studies out there on colon cancers looked at people or families who were in Africa, and then their families who moved to the West, and they followed them, and it's a longitudinal study. They followed them, and they found that people who in the East or in Africa, because of their diet, they had less cancer than people who are actually in the West consuming this Western diet. This Western diet is partly responsible for all kind of GI cancers, esophagus, gastric, colon in particular. So diet, nutrition is very important.
And cardiovascular disease.
Cardiovascular,
which is
that's
the number
totally
one killer.
separate. That's
Yes.
the number one killer. But, cancer is right there behind. So these are non-communicable diseases. We always talk about communicable diseases. I think in the 80s, communicable diseases killed a lot of men. That's HIV and all of that, right? But now we're talking about non-communicable diseases that are becoming the epidemic. And the non-communicable diseases like obesity is one of those, and then
Or
poor
hypertension.
nutrition. High blood pressure is the silent killer. A lot of
Exactly.
people are walking around with high blood pressure, and I mean, you don't even know because you don't feel it. You don't feel it until you get a stroke or the kidneys
Or your erections are failing.
Yes, obviously for the men, the erection failing, and that's when they run to the doctor to get the medication, and you find out that you got high blood pressure.
And then even then, most of them do not accept
They
it.
don't want to take it, right?
They'll take their meds for 2 weeks, and then they live in denial, and then they're
Guys,
fine.
you got to take the blood pressure medication, and Dr. Pinto has the triple special. He's gonna give you some other stuff to help you with that, but
Yeah,
Yes.
but we'll talk even more about hypertension. How many classes of drugs are there for antihypertension? There's ACE inhibitors, beta, calcium channel blockers, diuretics. They're a mixture. There's so many different ones.
There's a million.
For certain people, yes, we know certain classes, and I keep saying this, we know it causes some erectile dysfunction. It causes some decrease in sexual libido. The answer is not to stop the medication. It's to tell your physician so they can change you to a high blood pressure medication that has your blood pressure controlled, preventing you from getting a stroke or heart attack or going to kidney failure or losing your eyesight or getting erectile dysfunction. And still you can be a healthier you without the side effects.
Absolutely. And it's about maintaining health, and being aware of these non-communicable diseases. And if you have high blood pressure, again, it's easily treatable. And it's something that can easily be controlled. We don't ever talk about curing high blood pressure. We talk about managing high blood pressure, right? And there's so much effective medications out there that can do that. Same with cancer. I know we always talk about curing cancer. We can control it, right? Diabetes, we can control diabetes. People live long with diabetes if they take the medication, do the right thing, exercise, proper nutrition, and all of these. It's about health maintenance. As we age, this body breaks down, whether you like it or not. And luckily, science and medicine have found ways to help us to thrive. But we got to follow the rules, or we got to follow the medication and do certain things, right?
And a lot of it is denial, because I hear it all the time. I'm sure you hear it all the time. Men, they say, all right, I stopped the salt. I lost 5 pounds. I don't need the blood pressure medication. I don't believe that reading I just got in your office. It's white coat syndrome, that 226 over 118. I don't believe it.
Yeah, I always tell them I don't wear a white coat, 'cause it can't be that, right? But again, it's taking responsibility for our own choices.
There was actually a study, and it was very well received. It was a New England Journal of Medicine. It looked at blood pressure cuffs that people use at home and how inaccurate they are. And some people base their entire existence and health and future on those readings, where studies have shown there might be 10 to 15 millimeters of mercury less than your actual blood pressure. So the expensive calibrated blood pressure machines that you see in your doctor's office, if it's an abnormal reading, they're going to recheck it. They're going to check. They're going to change your arm. They're going to ask you to sit or stand.
Absolutely.
They're going to let you see your physician, and then even before you leave the doctor's office, they're going to repeat it again. Obviously, you're not going to diagnose anything on one reading. If on the second visit it's the same result, please, as a patient, accept it, because that could be the death of you in so many ways. And for Bahamian men, the first thing that's going to die is your erection.
Yeah, that's a problem for Bahamian men, right?
Yeah.
For all men, actually, but yeah, that's a problem.
Particularly Bahamian men. If you ask a typical Bahamian man, would you rather lose 3 fingers on your left hand or lose your erection for life? Most people be walking around with 2 fingers on the left hand. So when we talk about cancer screening and we talk about the future of cancer screening, we need to actually think about that in terms of there are really only 5 cancer screening tools that we use in our armament, 5 main ones. And one of them, obviously, for urologists is PSA, prostate-specific antigen, which is not very sensitive. It's not very specific. There are a lot of false negatives, a lot of false positives.
So I think you should probably take this time to, when you say sensitive and specific, educate our audience on what you mean by that.
So we want to know that, is that likely to be showing that you do have the cancer, or is it is there a high probability that you're missing the cancer?
Exactly.
By that? Yes.
So a sensitive test is the test that's going to determine the true positives, right? So you want a very sensitive test if you're going to screen people, because you want to pick up the positive people. A specific test is those tests that pretty much identifies the people who are negative, who don't have the disease, but really. So for screening, we want a positive test. And so as we had mentioned before, PSA, for example, is a type of secondary prevention, right? Where you identify something early. You already have it, and it goes up. And that's how you early identification like that. So PSA should be Well, you should hope that it's very, very sensitive, just like mammography. Mammography is a secondary prevention test, and it has to be very sensitive to sort of pick out those people who have the disease within the population.
The problem with mammography and in this society is that there are a lot of women who inherently have dense breasts.
Yes.
And mammography is not very accurate because on mammography, dense breasts, early tumor will just show up as white. What is the role of ultrasound? What is the role of MRI?
So hence, again, so as part of the reporting for a mammography or mammogram is to now report the density. And if there's a very dense breast, you then actually have to get an ultrasound. So mammography is actually more sensitive than ultrasound, but it's just less sensitive with dense breasts. And so therefore you add the ultrasound to improve the sensitivity of that. MRI is a very specific test, and sometimes it's overly sensitive. And plus it's expensive. The best screening test out there is something that is sensitive, it's affordable, and is easily accessible. A lot of people can't afford MRI, so we can't use MRI to screen the population. The other thing about MRI is that it'll pick up everything. So you're not going to be using an MRI to screen someone because they'll be getting all kind of biopsies. The role of MRI in screening is in very high-risk people. For example, patients whose risk is calculated greater than 25%. And that's particularly those women with the BRCA gene or other hormonal, or any other genetic breast cancer syndrome.
But when we
got a call? Oh.
Yeah, we have a call. Good evening. This is Urologist Speaks.
Yeah, Dr. Pinto, I was listening to the program. I like learning. And thank you, Doctor, for the explaining the pathway through the humoral pathway through the blood of the cancer metastasizing. Because I knew somewhere down the line, the lymphatic system is a filtration system for the immune system. But I was taken aback just now in the conversation about MRIs, right? And the thing is, you said boldly that a lot of people can't afford it. So then it's not, the burden doesn't lie on you or Dr. Pinto, but Dr. Pinto is in this fight. So as it relates to this, for me, an MRI has to cost $1 billion because the Beeman taxpayer doesn't deserve it. So I'm looking at it objectively. I mean, because it's good to have dialogue with people. As a doctor, that shouldn't be, what I'm saying is an MRI should be in the hospital. So then if the relevant authorities, if they care about healthcare, then an MRI would have been introduced. So obviously I said years ago that we are being kidnapped, given the fact that if an MRI, even if they use one enhanced with AI, with algorithms to be able to detect a cancer faster than a doctor, then it would benefit the people because then you would be stopping the cancer in its tracks, coinciding with proper blood works, et cetera, et cetera. So it's just sickening to keep hearing that. I've looked online on MRIs, and some of them are not expensive. I don't know which ones at the top of the line or whatever. I don't make them, but I just thought it's high time. I know Dr. Pinto's in this fight, but I'm taken aback by it because it's for too long now. They're not interested in saving people's lives. I've had an ultrasound, I've had a CAT scan, et cetera, et cetera. But we know that the MRI will be able to impede and intercept cancer, the tumors as they grow. And it's just sickening that they haven't put it in the hospitals yet, but yet still they're telling me.
Let's clarify that though.
About healthcare, they don't care. And then I just listen as it relates to blood pressure. I think for blood pressure, maybe medication would help if someone is older and they live a sedentary lifestyle and they are incapacitated in some way. But for a young person to be diagnosed with blood pressure, because I was having low blood pressure up until I was like 50, and that slowed down my kidney after a surgery. I don't know if Dr. Pinto knows, but what I'm saying is as a young person, let's say under 50, under 40, a doctor shouldn't just jump and prescribe them blood pressure medication because it has to be something else. It could be the imbalance in the interstitial or the exercise fluid. It just don't. You see, don't get what I'm saying? Yeah, let me listen. Yeah.
So,
well, let me just talk about MRI from my perspective. As a urologist, MRI is an imperative part of modern urology. There's no debate about that. That's an accepted fact. In terms of, we just spoke about PSA, prostate-specific antigen, which is a blood test that we use in screening for prostate cancer. It's not specific to prostate cancer. It's specific to the prostate gland. it's produced by the prostate epithelial cells. So there anything in terms of inflammation of the prostate, infection of the prostate, if you put any form of extrinsic compression on the prostate in the form of a half-full bladder, incomplete bladder emptying, that's going to make it shoot up. If you go into retention and we have to put in a catheter, your PSA is going to shoot up for that entire month until we make a new form of PSA. So MRI actually has found, and this is not debatable, conclusive, 70% of prostate biopsies that we previously would have done just because the PSA was elevated are now found to be not indicated when we do an MRI. So anybody who has an elevated PSA, I'm going to get an MRI of their pelvis and their prostate before we even consider doing a biopsy for many reasons. First of all, it can preclude us not doing 7 out of 10 of those biopsies, and biopsies are not pleasant.
Right. So, Greg, what you're saying is that the role of MRI is particularly organ specific, right?
Correct.
So in the prostate, you can say that. And again, you would use an MRI in patients who have elevated PSA. So you would have already done a primary screening before then you apply that MRI.
Yes.
Listen, cost is real, okay? And we could be emotional about it, but cost is real. MRI is expensive, whether you like it or not. And you cannot use an MRI to screen the entire population. If you did that, and all recognize, and I'm a taxpayer, and taxpayers is what fund the government or fund the health services, and it's a limited resource. So sometimes we get a little emotional about this, right? But again, if we start screening people with MRI who are, and screening again is screening people who without disease to determine whether they have disease or they're higher risk, you can't apply it's almost like taking a bazooka to try to kill an ant, right? You can't do that. It's very expensive and it does not help. So in breast cancer, a mammogram is a cheaper study. It's still more sensitive, and it can pick out those people who are positive. For when you recognize people who are higher risk and you need further testing, that's when an MRI comes in. So it can't be broadly used on an entire population because you'll break the bank and you wouldn't even have antibiotics to treat anything. Okay?
I agree.
So we have to
understand.
Yes. We have to understand that our health resources are finite, whether we like it or not. Right?
But one point I will have to make is that we need MRI in our public system.
We do.
And not just
We
from
do.
urology standpoint,
I
not
totally
just from
agree.
a surgical standpoint,
agree.
in terms of spinal pathology, spinal
We do.
trauma, brain malignancies.
That's not the point.
Yes.
We're talking about
I agree.
screening.
I agree.
We're talking about screening. And
No, I'm
prevention.
just making a point that 22 made that we need MRI. That is correct.
I understand.
Yes.
But let's be real about this, right? We do need MRI in the health system. We also need antibiotics. We need penicillin. We need vaccines. We need all of that.
We need beds.
We need beds, okay? We need all of these things. And all of them come from a finite pool. And perhaps we need, people to come and donate and support and help, right? And maybe we can get a donation of an MRI. Who knows? Yeah, right? But yes, we do need it. But we have to apply resources appropriately. That's just the way it is. That's a life.
Public-private partnerships is wonderful. I think I wrote exhaustively for 4 years, and eventually I got a new laser machine for Princess Margaret Hospital. I got a new bipolar state-of-the-art minimally invasive resection prostate machine for
and that's
so
and
it
that's
can be
great.
done. Yeah.
It can be done, and we have many people in the country who are wealthy, and perhaps if they're approached in the right way, they will donate. But again, one of the things I always try to say is we have to reduce our reliance on government, and sometimes as citizens, we need to try to improve our own environment. Because the government has finite resources. And so if we can get like the donation for the laser, like the donation for stop blaming the government for all of that. No disrespect to anybody, but we need to try to improve our own environments sometimes too. You got another call?
Yes, good evening. This is Urologist
Great
speaks.
conversation.
Hello.
Yes, yes.
Yeah, I hate to call again. I really hate to call again, right?
We love when you call.
But, I find it quite disparaging for me because I didn't say that screen everybody. I mean, you're a doctor, you're well learned, but I can't let you gaslight me as to what is right and what is wrong. You did agree that an MRI is needed.
Absolutely.
So what I'm saying is, let's be humane here. It's a one-time cost. The taxpayers can pay for it. It doesn't cost $1 million. It's not that expensive, and they have different qualities and different types.
Agreed. There are 5 MRIs in private in Little New Providence. 5.
It's a one-time cost. I mean,
It's actually not a one-time
people
cost.
would be able to go in the hospital
right?
and pay for it. So it would be at a reduced price, but it wouldn't be free. So, I mean, families would still have to come up. Let's say if it's $800. Instead of being $1,500, it could be $700, it could be $600.
You can get an MRI of your pelvis in private for $500.
And there's no impediment in healthcare.
So you and I don't disagree.
People, it's real time now.
You and I don't disagree, right? You and I don't disagree. And I've worked in the health system and in PMH and, for many years, probably the past 25 years. We do need an MRI in the system. That's not what the debate is about. We do need it. And when, and the government and the administrators have to recognize that we do, every advance in technology that adds value to diagnostics or treatment of the Bahamian people needs to happen. So we're not going to debate that at all. That's not an issue. We have to adequately use those resources, though, because, again, resources are finite. I would like to bring robotic surgery in PMH right now. I would. But that will improve a lot of people's lives. But again, it's a resource that we don't have. We got another call? Okay, great.
Good evening.
Yes, good evening, Mr. Pinto.
Pinto, yes.
Pinto.
Yes.
Pinto.
Yes.
And also the other...
Dr. Wesley Francis, yes.
Yeah. Listen, now, I listened to the other caller very attentively, and I also listened to the response from, Dr. Wesley?
Dr. Francis.
Francis?
Yes.
Yeah, your response isn't one that I would accept as a taxpayer. I would not accept it because it is inconceivable that you're going to think that an MRI machine, not that it should be used in every single case, but when we're going to take our resources and spend it foolishly by talking about, and I don't want you to get involved because that's from a political standpoint, where you could have people be spending something like millions of dollars for consultant, and we don't have an MRI in the hospital. Just show me how that really makes sense, sir. All right? I'm just of average intelligence, but show me. I'm not a physician.
So,
by no means.
Let me take Dr. Francis off the hook.
Hold on. No. I can stand up for myself. Okay. I can stand up for myself. Listen, I don't disagree with you at all. You and I are in agreement. But I think this radio program is to try to educate.
Yes, I understand that, but
we're not going to get into political arguments.
Education.
We're not going to get into political arguments.
As a physician, you got to let's deal with the facts. The facts is it should have been there years ago. We shouldn't even be.
And I'm not disagreeing with you.
At this point,
I'm not even disagreeing with you on that. Just hear me out. I'm not disagreeing with you on that. We were talking about screening. I agree with you. We should have MRIs in the public sector. I 100% believe in that. I agree with that. We also have to recognize that resources are limited. Now, how they use the resources, that's beyond the scope of this program. And we can get there. But I agree with you, caller. I'm not disagreeing with you at all. And I'm not disagreeing with the former caller either. It's just about how we use the resources that we have to get the greatest value for the patients so that they have the best outcomes. That's all we say.
You also have to look at it from the other perspective. What is the untold costs, emotional costs, financial costs for metastatic disease, where if we had some imaging to pick up things early, we could have precluded them from going down that road. For some drugs, for prostate cancer that is castrate resistant, it might be $10,000, $12,000 a month. The cost of immunotherapy can be $30,000 a month.
Well, absolutely.
If we could limit those number of overwhelming cases where we have metastatic disease and persons are dying in their prime, an MRI can go a long way in terms of, let's just say, let's take away cancer. Let's talk about someone who's in a traffic accident.
But I
they
don't
need
want
an
anybody
MRI.
to get away with this, right?
Yeah.
And we need to, sometimes we need to talk about these things. And I like that we're having this discussion, right? But, we spend a lot of money, and you've taken care of a lot of patients with cervical cancer. A vaccine for cervical cancer is so much cheaper, right? And we can prevent so much people. So
we can eradicate
it, right? So there's more. Where do you apply your funds or resources to handle a population? And I think the best is on the prevention side. There's so much money to be spent on the other side and is wasted because we can use those and prevent. And again, we need to educate ourselves as to how we prevent getting cancers or getting sick, because, a lot of money is spent on the tertiary end, and sometimes it's not well spent. So let's focus on prevention. Let's focus on for example, we talked last week about, HPV vaccine. We could eradicate penile cancer. We could eradicate cervical cancer, right? And talk about mammography, and the thing about, and I want people to recognize, we're talking about MRI in the public sector, right? And I hope I don't get into hot water here. We just need a regular mammogram to work in the public sector sometimes.
Very much so.
I want the listeners to understand, I work in PMH. I work there every day. You understand? And I know what we don't have and what we have. I will love to have 2 working mammograms before I get 1 MRI.
Yes, even so.
Okay, that's important to know. That's important to know before people start to get emotional and all about these things. Okay?
I agree.
Because we want to get to maximize the effect, the benefit to patients. Okay, and it's not just a one-time cost. One of the things that the difficulties that we have in the public sector is maintenance. We buy things and we don't. Well, again, y'all can get me in trouble with my bosses, but maintaining things, it's not a one-time cost. You can get an MRI today or a CT scan today, and we have a CT scan. We never always used to have a CT scan, and it came through those private-public partnerships, and then it became solely public. But then what happens? No maintenance. It breaks down every other day.
Yes.
Because things have to be maintained. And I agree with the caller about how resources are spent. But again, that's beyond the scope of this program. Let's delve into that. I think all the programs in the days deal with all the politics and stuff like that. We're going to deal with education and helping people to understand how they could prevent health cancer and stuff.
Well, that's the purpose of this show. We're here to be proactive and to try to provide preventative medicine. We don't want to be reactionary. We want to provide preventative medicine. So I'm not going to get into the depressing lack of supplies and funds at PMH. We're here trying to do things that we as individuals can. But
sometimes we need to get a discussion. Yes. Today was a good show. Yeah. I like the call. I love having a discussion, a good debate. And at the end of the day, though, we always have to recognize that health maintenance is important. And let's figure out how we can do better for ourselves.
Yeah, MRI is wonderful, but I remember throughout the years I have to purchase biopsy needles and catheters and stents and prostate biopsy guides myself.
They don't want to get us started on this. We can get in trouble if we do that, right? So let's stick to the program.
Okay. So let's talk about something quickly and positive. We're talking about the future of cancer screening. So there is something on the horizon. It's actually readily available. It's called Greggory, and it looks for cancer-specific signals in your blood. It's able to do that by detecting cell-free DNA that is shed by a tumor. It can also detect where in the body that cancer signal is coming from. So basically, a positive signal with a Greggory test, you just need a confirmatory diagnostic tool to go further with that. So basically 50 different cancers can be detected just with a simple blood test. And that's going to revolutionize cancer screening.
Well, it is. And it's not entirely proven yet. Some more research needs to be done, but it's going to be a game changer.
It's basically
it's
like
not
liquid biopsy.
Yes. But on the prevention side, or early detection side.
Yes.
And so every tumor cell secretes DNA that is put into the blood, and you get that blood, and you're able to then identify that. And that's how this test does. It's not approved by insurance. It's not approved by the FDA, but it's a company in the U.S. called Grail. And those of you who buy stocks, y'all should look at the stock of that company, because that, I think, is going to be the next best test out there for cancer screening.
Yes, so we've said a handful. I think we went a little bit off track with our emotions in terms of what we've personally gone through with PMH, but we want to let the population know that there are many modifiable risk factors that you can control that can substantially reduce your risk of cancer. Even for alcohol consumption, that can reduce your chance of getting breast cancer by as much as 16.4%. So there are things that we can do. Make sure that you're healthy in terms of what you live and in terms of what you eat. Get exercise 3 times a week. Make sure your body mass index is in the normal range. And get your annual physicals, particularly the men. Women, you don't usually need to tell them, but please get your annual physicals. This is Urologist Speaks with Dr. Greggory Pinto, and thank you, Dr. Wesley Francis.
Good night, Bahamas.
Down with your best, get the urologist.